Being an optometrist in the 2024 glaucoma landscape feels like both an opportunity but also a double-edged sword. On the opportunity side, we have a growing patient population with glaucoma. We have improved diagnostics to better be able to detect the condition, hopefully earlier, and we have an explosion of treatment options to have a more customized treatment approach for our patient, ultimately improving patient outcomes. But on the other side of the sword, it's difficult to keep track of all these changes and innovations, what's new, and how does this come into my busy practice. I'm Mitch Ibach. I'm an optometrist with Vance Thompson Vision in Sioux Falls, South Dakota, and I'm here to help. We'll talk through some of the innovations in glaucoma, the improvements and explosion in treatment options, and then finally I'll try to give you a little bit of my algorithm in patient flow and taking care of patients. Early detection is paramount in modern day glaucoma because unfortunately glaucoma is irreversible. And so when a patient undergoes damage to the optic nerve or cupping, when a patient loses some of their peripheral or even central visual field, unfortunately we can't get that back. I think in 2024 as an optometrist managing glaucoma at a high level, you have to have a minimum of 4 key things. Number 1, you have to have an OCT. Number 2, you have to have perimetry or some way to look at the visual field. We have to be able to look at the optic nerve, and we have to be able to check eye pressure. There's lots of other technologies that can make this easy. And so as optometrists, we have to grow and elevate into being able to feel comfortable diagnosing glaucoma, treating glaucoma, monitoring for progression glaucoma, and ultimately just doing these 3 things so that we can all elevate for patient care with growing volumes. Monitoring glaucoma progression, I think, is important to have an individualized compass. What I mean by that is find your true north. What's most important to you? And I would encourage you to have OCT and visual field in that. We don't want to be overreactive to one intraocular pressure measurement, and so I'll try to kind of take out the outliers, but if you start to see everything adding up on the compass together, put those puzzle pieces together, but make sure that OCT and visual field are part of your true north. I think taking some time for patient education in the glaucoma space is really important. I really desire a well-educated patient because I want him or her to be on the team for their glaucoma management. If they build trust in me and I build trust in them, then I know that they're going to prescribe or be willing to do the things that I'm asking to in a surgical space, in a glaucoma drop space, in a laser space. We need that patient to feel comfortable, as well as when they're educated, they're just willing to be on and play on that team more. When I'm talking to a glaucoma patient in front of me, I like to say that the diagnosis of glaucoma is all these different things. We put all these different tests together, but treatment is unilateral. It's just one thing. We try to lower the intraocular pressure, and we really have 4 mainstays or pillars to help do that. But let's start with topical glaucoma drops. In the last 5 to 10 years, we've brought to market now Rho kinase inhibition, where we can try to treat the trabecular meshwork, increase conventional outflow, as really the primary mechanism in those medications. We have a nitric oxide donor component where, again, we're targeting the trabecular meshwork, the diseased tissue in most of our glaucoma patients. And then we also have a newly emphasis on trying to preserve the ocular surface in our glaucoma patients. And so we have a prostaglandin analog that's now fully preservative free. We have a prostaglandin analog that is BAK free. And so again, trying not to induce changes or adverse events in our glaucoma patients with some of their topical glaucoma drops. Unfortunately, the downside of topical glaucoma drops is patient compliance. And so I think we have to have this focus on how do we give our patients less installations, less bottles, so combining things, ultimately finding an efficacious approach or cocktail management system that works for that patient. Second is laser trabeculoplasty. This is almost universally now selective laser trabeculoplasty, and I think SLT definitely should be considered as first-line treatment in our glaucoma patients. This is something that we can do same day in our practice. It can be done on both eyes the same day. It's very, very safe as well as efficacious. And so when I'm talking about SLT with patients, I really say we have this treatment approach that we can do where we're trying to reinvigorate your natural drain to get fluid to flow out better. Unfortunately, it's not a forever treatment, but it is repeatable. And so I think that the safety of SLT really just should empower us to be prescribing or recommending this more for our patients. Third, we have drug delivery, putting really, really good molecules, but just into the patient's eye rather than through a topical glaucoma drop. We can leverage these molecules, these medications that work well. We're just taking that out of our patient's hands a little bit. And now we're getting extended duration of treatment, whether that's 12 months, whether that's 36 months with some of the technologies we now have on the market. Again, we have patients and we can have a more customized approach for them, and we're still giving them that molecule or what they need to really lower the eye pressure. And then finally, we have glaucoma surgeries, and we'll branch that off into minimally invasive glaucoma surgeries, these micro-invasive surgeries. They're minimally traumatic. They're at least moderately efficacious for our patients, but again, they're prioritizing safety. And so if we further branch off, we have patients who have a concomitant cataract. They're going into the operating room to have cataract surgery. They also have glaucoma. Do not miss this timestamp in his or her life to be able to help them see better with cataract surgery, but also lower their risk of glaucoma progression, maybe decrease their drop burden. And so a lot of our minimally invasive glaucoma surgeries are working in the anatomical angle, the patient's natural drainage pathway. We can work on the trabecular meshwork and Schlemm's canal. We can work on distal collector channels. We also have some in the subconjunctival space. But minimally invasive glaucoma surgeries is not only at the time of cataract surgery. We have standalone procedures as well. And in the standalone space, it's a little bit trickier to try to find what's the patient, what's the right candidate for that. And so in my practice, the easy one is the patient that's progressing. We have a patient who's tried other things, they're still progressing, we're going to think about standalone MIGS. We also have the patient who's maybe not good with their eye drops. They've told us on more than one occasion, I'm not doing a great job of taking my topical glaucoma drops, and so we'll intervene with standalone minimally invasive glaucoma surgeries. And then finally, and this is, I think, evolving in 2023, 2024, is what's maximally tolerated drops for patients? Because we used to think that was maybe 4 drops, then it's 3 drops. I have some patients where it's really 0 drops. They just don't tolerate drops well for reasons X, Y, Z. And so we have to be able to meet that patient's needs. And sometimes standalone minimally invasive glaucoma surgeries is the right option for that patient where it's really 0 or 1 maximally tolerated medication. And then finally is filtration surgeries or incisional glaucoma surgeries. In our practice, this is really kind of the last resort. We've tried A, B, and C, the 3 things we've talked about previously, before we're going to what's commonly referred to as a tube shunt or a trabeculotomy. And so these surgeries are definitely efficacious, but they have a shorter window of time that they work. They're going to fail. And unfortunately, we're putting that patient at bigger risk. There's bigger risks and side effects that can come with this, both intraoperatively and postoperatively. One of the big ones to think about is hypotony. If the eye pressure goes too low, boy, we're at the mercy of that eye kind of healing itself. And so we try to save those for last resort in our practice. As I'm thinking through my glaucoma treatment options for patients, we'll work through 3 common scenarios. One is the severity of their glaucoma. And it's just harder when we start in the severe stage. And so I always think of glaucoma treatment as really risk versus reward. And if we can catch patients early, we just have a lot more options because the severity hasn't gotten there yet. The second scenario we'll talk about is staging. I think in 2024, optometrists really need to feel comfortable staging glaucoma. First, this is important because we need to do it for billing and coding. And so visual field characterization is a big one. You can get this from the American Glaucoma Society. The American Academy of Ophthalmology has preferred practice guidelines, but find something you're comfortable with for staging glaucoma. According to those preferred practice guidelines, no visual field loss in the mild stage, we've actually caught them before they've had irreversible damage. Moderate to severe gets a little bit tougher, but I think staging is really, really important. Staging glaucoma based on visual field also helps me for when am I going to bring that patient back? What's follow-up? What does my target IOP look like? And the third scenario to think about is rate of progression. who's going to be a fast progressor, who's a slow progressor. If someone can give us a diagnostic that's going to tell us that, or we can get some type of blood test, a lab test, that's really the holy grail. Because right now, finding who's going to be a fast progressor versus who's a slow progressor is really something that we find because they just progressed. And so it's really just recalibrating after a patient's progressed. We say, well, we got to be more aggressive here. Slow progressors are great. That's the patient where maybe we can take down some of the things that we're doing for treatment. But unfortunately, we really don't find that out until you're farther along in the disease process. Age is a big one for me with glaucoma management because we just have to take care of a patient who is 68 much different than we do a patient who's 88. Glaucoma is chronic. And so if I have a 60-year-old patient, I have 20 extra years compared to the 88-year-old patient where I got to keep non-progressing glaucoma. And so in a lot of these patients, we maybe have to be a little bit more aggressive because they have more years where we have to keep the disease from progressing. Second, surgical outcomes are much different in some of our older patients. An 88 or a 98-year-old patient just doesn't heal the way that some of our younger patients do. They also have a little bit more trepidation about going into the operating room sometimes, and they have other concomitant systemic health things that may prevent that. And so we treat these patients differently, especially if you're thinking about a filtration surgery like a tube shunt or a trabeculectomy. Boy, we really try to avoid those in some of our real geriatric patients because they're just not going to heal the way that some of our younger patients do. If we go second to lifestyle, we have really active patients. Our active patients maybe don't want to take 1 or 2 or 3 different bottles of drops, which could include 8, 9 installations of drops per day. And so I think as we're thinking through lifestyle, it's important to be realistic. In the pre-treatment conversation for patients, when we're trying to decide which path we're going to go down for their glaucoma treatment, I really like to set expectations for the patient. I think expectation setting starts with what's our target? Where are we trying to get to? I also like my patients to know that the target IOP, or what we're trying to achieve, is a fluid number. It's moving, and I also like to set a range because I don't want patients to come in and their eye pressure is 16, and I said, boy, I really want to be 15, and they're bummed out and they're losing sleep for the next 3 months because that's probably not making a difference in some of our patients. If I'm prescribing a topical drop formulation, I like to talk about potential side effects with the patient. It's much more manageable with the patient if you tell them this could be one of the things that we may run into. I also like to tell patients that very, very commonly these are not ocular infections. These are not always allergies to the medication, so that they know what could be coming down the pathway that we're going. Second, if I'm thinking a more procedural route, whether that be a laser procedure or whether that's a surgical procedure, I want patients to know the possible adverse effects or outcomes that could cause potential damage or vision loss in their eye. Remember, most of our procedures also need post-operative drops. And so when a patient's talking to us and they're telling us, I'm definitely not a good drop patient, well, I need you to use these drops for a period of time so that we can execute this safely for you. I recently had a patient who was referred into our practice from one of our optometric referral sources, and this patient had the angriest red eyelids I think I may have ever seen. It was almost an atopic dermatitis appearance. There was scaling and crusting. This patient had a controlled eye pressure, has been previously told that she was intolerant to a beta blocker. She also was currently taking alpha-2 adrenergic or brimonidine 0.2% twice a day in both eyes. And as we went through her testing, I got that before I went into the exam room. This was a patient who had moderate glaucoma. This was a patient who had a superior arcuate visual field defect in both eyes. This was a patient that had OCT damage in both eyes. She was pseudophakic, so she had already had cataract surgery, and for this specific patient, this was an exposure conjunctivitis. About 15 to 20% of our patients over time, I think, will get a delayed type 4 hypersensitivity to brimonidine or to alpha-2 adrenergic agonists. And so this patient, you could have put any other drop that you wanted onto this eye, and those eyelids were still going to be angry. That was still going to be a red eye. And so for this patient, the key was really to get the topical glaucoma drop off of the eye. And so what we did was had a customized approach where we combined selective laser trabeculoplasty with an intracameral drug delivery implant for this patient. And so now we're leveraging a prostaglandin analog inside the eye. We've also hopefully opened up the drain in the eye. And so now we have improved conventional outflow through the trabecular meshwork. Our prostaglandin drug delivery device is hopefully going to open up the uveoscleral pathway, and we're off of the drug that is causing this patient to have the angriest eyelids and red eyes I think I've seen. Number one, if you have a patient who has mild glaucoma, and we said that's really before visual field loss, definitely before visual field loss that's affecting the patient's vision to where they can tell, we have to make sure that what we're prescribing or the treatment approach is not causing more burden than what they had before. The second big tip or pearl that I have is build a family of counterparts who you can work with. Build a relationship, whether that's other optometrists, whether that's a glaucoma surgeon, or someone who can help you when times get tough. Someone you can ask a question to, as well as someone you feel comfortable referring your patients to, because as an optometrist, we want to work in a collaborative way with our surgeons so that we can offer these treatments and these modalities to ultimately lower their eye pressure.